So good morning, everyone. I am going to introduce our speaker, Abbie Begnaud, this morning. Abbie is an assistant professor in the pulmonary division in the Department of Medicine and has been here since 2014 and is in charge of our lung cancer screening program at the University of Minnesota, most of which occurs in the CSC, but actually is distributed around at different sites. So I bumped into Abbie a number of years ago working on a lung cancer screening study, and she has several interests in particular, with particular relevance to the Cancer Center. In addition to just the general question of lung cancer screening. One area is in incidental findings, which is always a problem in screening. And then the other one, which she's going to be talking about today, is lung cancer screening in diverse populations and specifically among American Indians who have an extremely high prevalence of smoking. She's also had an interest both in screening and in monitoring and looking at aspects of treatment of lung cancer in American Indians. So I can promise this is going to be an interesting talk and highly relevant to our catchment area in Minnesota. So welcome, Abbie.
Thank you, Anne. Okay, this is on. I see some familiar faces. Thank you all for coming today. As Anne mentioned, I do have a variety of interests related to lung cancer and health disparities. Today I'm going to spend, not going to talk a whole lot about my own work, but talk more about health disparities and lung cancer in general. My objectives are to give you a little bit of an overview of the epidemiology of lung cancer. I anticipate we probably have a pretty diverse audience, so I want to make sure everybody understands the starting point. And then I'm going to provide you some examples of how national data can actually mask health disparities in lung cancer. But really, my overall objective today is to start brainstorming solutions and to inspire researchers to help us fix this problem. Most discussions of health disparities spend a lot of time talking about the disparities. They've been well measured and well documented, but we really need to start moving ourselves more towards some solutions. So the burden of lung cancer is significant. It's estimated about 156,000 people die of lung cancer every year. This is more than several other cancers combined. You might hear this described in different ways, usually prostate, breast, colon, possibly even cervical cancers. All of those cancers combined are fewer than lung cancer. The 5-year survival, oh, you want me to use this? Oh. Okay, thanks. 5-year survival for lung cancer is about 19%, so that's really quite low. So only 19% of people who are diagnosed with lung cancer will be alive in 5 years. Since 1987, more women have died from lung cancer than breast cancer. This is perhaps a surprising estimate for many people. You hear quite a lot about breast cancer. We're wrapping up Breast Cancer Awareness Month right now. There's pink everywhere that you look. You may not know that November is actually Lung Cancer Awareness Month. You probably won't see quite as much awareness during Lung Cancer Awareness Month, so we do need more of that. The color for lung cancer is actually white. So I suppose you could just imagine that all of the white that you see is related to lung cancer, but that would probably be my optimism and not reality. Most people, of course, attribute lung cancer to being a smoking person's problem, a smoking-related disease, which certainly is true, but lung cancer in never smokers is the 7th leading cause of cancer-related death. So lung cancer in never smokers is actually also a significant problem. So here are some numbers from the CDC in terms of trends in lung cancer over the last approximately 20 years. So one thing you notice here on the left is that the annual number of cancer deaths really hasn't changed very much since 1999. When you look at the trend of rates, you do start to see a slight decline over time. In terms of the 5-year survival, 19% that I mentioned earlier is a new number for us. That's an exciting change from the number when I was in training and the previous number of 17% 5-year mortality. So we're really excited about those 2% and this little teeny tiny slope down. what is responsible for the downtrend in lung cancer mortality? So certainly tobacco control and change in tobacco use habits over time is mostly important. There have also been some improvements in therapies. I'm not going to spend a lot of time today talking about the specifics of these, but just so you have an idea of what we are looking at in the lung cancer space, stereotactic body radiation. So this is a focused radiation treatment for early stage lung cancer, is one new treatment that has probably improved survival in people who were unable to undergo the gold standard therapy for early stage lung cancer, which is surgical resection. There have been recognition of mutations, which I assume many people in this room are aware of, and development of targeted therapies so that more effective and more tolerable therapies are available for lung cancer, especially lung cancer that's not early stage and not eligible for the gold standard surgical resection treatment. And then, of course, screening, as we talked a little bit about already. Lung cancer screening is a new recommendation. I'll tell you more about this later, but basically lung cancer screening is almost certainly not contributing to any downward trend in lung cancer mortality yet. Screening has been recommended for about the last 6 years, so it's not yet contributing to a downtrend, but of course the hope is that lung cancer screening will dramatically impact lung cancer mortality. So since this is a talk about health disparities, I want to provide you a couple of definitions for us to move forward with. According to the World Health Organization, of course, health is a complete state of physical, social, and mental well-being, not merely the absence of disease. Inequality is a description of differences in rates between groups and the distribution of the population. So one good example of that is that there is an inequality in mobility amongst older and younger people. So there's a difference, it's not the same, but maybe attributable to things that you might expect. Health equity describes the fair distribution of health determinants, outcomes, and resources within and between segments of the population, regardless of their social standing. So inequity, of course, is a difference in the distribution of these resources. So that brings us to understanding what a health disparity is. So according to the Department of Health and Human Services, a health difference that is closely linked to economic, social, or environmental disadvantages. So health disparities adversely affect groups of people who have systematically experienced greater obstacles to health. So today we're talking about health disparities. So not only differences, but basically unfair and unexplainable through biologic mechanism differences. Groups can experience health disparities on the basis of a variety of personal characteristics, race or ethnicity, socioeconomic status, geographic distribution and geographic location, sex, gender identity, sexual orientation, and then abilities and disabilities. So each of these types of distinctions or the groups to which people belong to might apply differently to health disparities in different diseases. Today I'm going to focus on the first few. We're not going to talk too much about the last couple. So lung cancer incidence in the United States, this is just a very brief overview if you're not in the weeds kind of person. If you look at men and women, it's a little bit different when we compare race and ethnicity incidence. Hispanics overall have the lowest incidence of lung cancer for men and women, and then followed by Asians and Pacific Islanders. American Indians and Alaska Natives are right in the middle. Again, this is over a whole US population. And then non-Hispanic whites, and then followed by African Americans for men. And then in women, that is slightly reversed. So this is just incidence of lung cancer. So the most recent data from the CDC here shows rate of new cancers. This is over approximately the last 20 years, from 1999 to 2016. So the highest rate, as we saw in men, is amongst Blacks, and in women, it's amongst whites. The mortality chart, so this is incidence, the mortality chart looks exactly the same, because as we discussed, lung cancer mortality is pretty severe. So if we start to break it down and think about these health disparities, we need to drill down into smaller groups and look at the numbers in a little bit different way. So this is a paper which reviewed SEER data to look at different cancer incidence and mortality and other disparities by race and also by socioeconomic status. So what they saw by and large was that socioeconomic status was actually a very important predictor for lung cancer incidence, lung cancer mortality, most of the outcomes that you're looking at for lung cancer and other cancers as well. So this graph actually shows all cancers, but I think it is really nice to illustrate the relationship between race and socioeconomic status. And so you'll see that for certain races, in this case, Blacks, and then especially American Indians, even at the highest level of socioeconomic status, which is the dark maroon color, you still see some disparities in cancer outcomes. But amongst each individual race and ethnic group, there is a huge gap based on socioeconomic status. So the lighter colors are the lowest quintile of socioeconomic status. So this is unpublished, but this was a presented abstract at the American Clinical Society of Oncology, American College of ASCO. I got the acronym wrong. I realized I'm like American Society of Clinical Oncology. So this was presented this year actually, and talks about healthcare costs. So again, on the socioeconomic status factor of disparities, of course, you know, people with highest out-of-pocket, this is not shocking, right? This is the type of stuff that you read and you go, yeah, duh. Somebody just crunched the numbers and figured that out, right? So patients with highest out-of-pocket costs were less likely to fill their prescriptions and had a shorter duration of treatment. So patients with biggest personal expenses typically paid $3,000 a month for their TKI. So TKI, again, most of you probably know, is a class of drugs that is a targeted treatment for lung cancer for people with specific types of mutations. So this is one of the things that has improved and revolutionized lung cancer treatment recently, but only if you can afford to pay $3,000 a month if you don't have good insurance. So another study looked at this and found that prior authorization, so if you have an insurance plan that requires prior authorization for imaging, then even when approvals were ultimately given, prior authorizations were delaying care, stressing out patients and their families, and burdening paperwork. So the insurance plans that have that, basically not as robust or good coverage, also contributes to some barriers. Even patients who ultimately got these TKIs, tyrosine kinase inhibitors, the targeted therapy, which is a newer, more tolerable lung cancer treatment, the people with the highest out-of-pocket costs died sooner. So these are people who were prescribed the drug, they got the drug, and they still died sooner. So out-of-pocket costs and healthcare costs really do exacerbate disparities in lung cancer, as was shown in this study. So this is another graph from the other multicolored graph. I really like this paper. Again, they are looking at race and ethnicity, or excuse me, they're looking at socioeconomic status. So this is lung cancer mortality over the last, 65 years. This particular graph shows lung cancer mortality in men. The thing I like about this graph, one, is it's multicolored, and I do appreciate that. The other thing that you'll see here, so the lowest quintile of socioeconomic status on this graph is red. So the red line is here. So back in 1950, low SES people actually had lower rates of lung cancer mortality. High SES is in this purple color, and that's the number here. So if you look at this graph, the thing that you see, of course, most dramatically is a couple. One is that lung cancer mortality was going up and up and up and peaked and is coming down. So the trends are improving. But the other thing that you notice is that you have a flip-flop of the curves here. So instead of the red low SES folks having the lowest lung cancer mortality, now they are at the highest. And the black, I'm sorry, it's black, that's high SES, but so that one completely flipped, basically. So what we're seeing is a much more dramatic change in lung cancer mortality over time for people in a high socioeconomic status. Going to shift gears a little bit and talk about this. I don't have too much about women, but this paper actually came out last year, and I think is really important for us to look at because we fall into one of these little bad zones here. So this paper looked at lung cancer death rates amongst women. So the paper here, they're showing us males, right? In this paper, they did not show a graph of lung cancer mortality rates in females because it was kind of boring. They were kind of on the downtrend. You didn't see this dramatic change in SES. This paper was looking more closely at death rates amongst women. So even though more men die of lung cancer, this was showing that there are a couple of areas in the country where there are some what they described as hotspots. So these hotspots are areas where the rate of lung cancer death is changing more dramatically than other parts of the country. So the hotspot that we're in, they labeled the Midwest, of course, flyover states, right? And then the other one they labeled as the South there. So in our region, this hotspot here, the lung cancer mortality rates for women are increasing by 13% over this period of time, this 25-year period that they looked at. I'm going to talk a little bit about African Americans who are disproportionately affected by lung cancer nationally. Incidence and survival outcomes are disproportionate. These differences were first formally noted and recorded in 1972 and have been continuously observed since then. The SEER database started in 1973, and so it has been continuously observed since that time. At the present time, age-adjusted lung cancer incidence for African Americans is about 32% higher than in people of European descent. And again, the disparities have been most predominant amongst men, which is a common theme for lung cancer. So these are national numbers. So the red bars show all races. The white, the white numbers are in green, and then the blue bars indicate numbers for African Americans. So these two show stage at presentation for lung cancer, and then survival by stage. So the lung cancer survival by stage graph, as you can see, doesn't change very much between races, but you do see that the blue bars here, even for localized lung cancer, have slightly lower survival amongst all of the groups, actually. Stage at presentation. So this is really, really important for lung cancer. Stage at presentation dramatically impacts your ability to survive your lung cancer. Slightly more African Americans present with a later stage lung cancer. This is a problem for everybody with lung cancer because there are typically no symptoms when lung cancer is early, and without screening, you can only detect it at a distant stage. But even still, African Americans are more likely to present at a distant stage with their lung cancer. So this is a recent paper that was published in the CHEST journal looking at racial and ethnic disparities in early stage lung cancer survival. So again, early stage lung cancer is where you have your best chance for survival. If you can catch it early, there is a reasonably good chance, maybe 80% or so, 5-year survival. So in this study, they found that Hispanics and non-Hispanic Asians experienced better overall survival from lung cancer. For Black patients, surgery was recommended less often for early stage lung cancer than for any of the other racial and ethnic groups, and that non-Hispanic Blacks experienced worse overall survival compared with non-Hispanic whites. They did also observe worse survival from competing causes of death. So of course, lung cancer is not the only problem affecting health disparities in mortality. Cardiovascular disease and other cancers also contributed to poor survival. So as I mentioned, lung cancer, we said surgical resection here was recommended less often for Black patients. And again, that's the gold standard. That's your best chance for cure with lung cancer. Other standard therapies for lung cancer, again, we see Blacks and Native Americans were shown to be more likely to refuse surgery. So the previous study showed a lower rate of offering lung cancer surgery to Blacks with lung cancer. This study showed that Blacks and Native Americans were more likely to refuse surgery for stage 1. The other factors associated with refusing the gold standard therapy for lung cancer was insurance status. So if you have Medicaid, which if you don't know is a state-based, usually need-based program for poor people. The odds ratio is 2.2 compared to Medicare. So Medicare is typically given to people at the age of 65. So Medicaid population usually have lower socioeconomic status. In addition, chemotherapy refusal was also associated with insurance status. So people who were uninsured were 2.5 times more likely to refuse treatment for lung cancer, and people who were getting Medicaid were 1.5 more times likely than patients with Medicare to refuse chemotherapy. In addition, lower income and lower education, so again, socioeconomic factors were associated with refusal of treatment for lung cancer. So I'm going to shift gears and talk kind of a little bit broadly about how can we explain these disparities? Can these be, you may have already thought, maybe smoking habits explain a lot of the differences that we are seeing here. And certainly cigarette smoking is the strongest risk factor for lung cancer development. It is well documented, and I am not going to explain this nearly as well as some of the people that are sitting in front of me in terms of the tobacco and nicotine researchers that are available, but I will do my best. So heterogeneity in tobacco exposure across populations is a plausible explanation for disparities. It's been well documented that that in addition to smoking status, you know, current smoker, never smoker, former smoker, and dose, which is how many cigarettes you smoke per day, there are other factors which impact your overall exposure to cigarette smoke. So the duration of your smoking time, if you started earlier and quit later, you have less successful quitting, the age at which you start smoking, other daily habits that indicate your nicotine addiction, time to first cigarette, if you're a daily smoker versus a non-daily smoker, the type of cigarette that you smoke, tar content, menthol cigarettes, and then smoking topography, which is sort of complicated, but basically describes how efficient you are at smoking a cigarette. If you can really get every last puff out of it, or you smoke a little bit and you can basically afford to just throw that one away and get another one later. So all of these are known contributors to the carcinogenesis of smoking and how it affects people differently, and have been associated with different types of groups. So African Americans diagnosed with lung cancer are significantly more likely to be intermittent or light smokers. They are more likely to start smoking later in life. And when matched for equal levels of smoking, African Americans do still experience a higher burden of lung cancer, suggesting that they may be more susceptible to lung cancer at lower doses of tobacco is one explanation. Lung cancer disparities exist in never smokers that we discussed here. So, and then of course, socioeconomic status, individuals tend to extract more tobacco and more nicotine. Like I said, they're more efficient. So when we frequently think about who's at high risk for lung cancer and how do we decide who's at high risk for lung cancer, we generally do a back of the envelope calculation of how long you've been smoking and how many cigarettes a day you smoke. But if you're really good at getting every last bit out of the fewer cigarettes a day that you smoke, then that might make that calculation for you less predictive of your risk for lung cancer. What about other risks for lung cancer? So it is estimated that maybe 10 to 25% of lung cancer cases occur in non-smokers, never smokers. This does include environmental smoke exposure, so that would be some of your secondhand smoke exposure. Other risk factors that have been cited are alcohol consumption, body mass index, geography, where you live, radon exposure, pollution, and other environmental exposures, either alternative or unidentified exposures, may contribute to risk for lung cancer. Of course, many sources of pollution, industrialization, urbanization, and radon are often located near or overexposing disadvantaged groups. There is definitely a genetic association with lung cancer. I would say from the perspective of a clinician, it's not well enough described that we can use it readily in our everyday practice, but certainly genome-wide association studies, linkage studies, even Mendelian inheritance has been associated with clusters of lung cancer in families, for example. So there clearly is a genetic component, maybe an interaction with their smoking. So this graph, I think, again, multicolored, so I like it a lot better, but is a pictorial way to describe what I just mentioned, which is that at lower smoking intensity, fewer cigarettes per day, health disparities really become more evident. So this four-part graph shows on the left-hand side, men on the top, women on the bottom, individuals who smoke about 10 cigarettes per day. And each colored line shows a different race or ethnic group. So this data is from the multi-ethnic cohort, which looked at individuals in California and Hawaii. So they have native Hawaiians. They don't have American Indians here. They have native Hawaiians since they looked at mostly California and Hawaii. So the top line here, which is dark blue, is African Americans. And then the next line is purple, which is native Hawaiians. This light blue line is whites. And then Japanese Americans and Latinos are down here in the, looks like red and green. On this side of this slide, you have men and women on the bottom who smoke 30 cigarettes per day. So, you know, the primary finding here is that amongst people who smoke fewer cigarettes per day, African Americans and in this study, native Hawaiians appear to be more susceptible to the carcinogenic effects or more likely to develop lung cancer. When you get to smoking 30 cigarettes a day, which is 1.5, you know, standard packages of cigarettes, the differences narrow out because at that point, everyone is being exposed to the degree that they're putting themselves at high risk for lung cancer. So again, I think this argues against excess smoking contributing to disparities in lung cancer. And also from my perspective for lung cancer screening is an important area to look at for how do we identify these people who are in this top part of the curve and identify their risk for lung cancer screening. So now that we've talked a little bit about Native Hawaiians, I'm going to move into the sort of more broad discussion of American Indians and Alaska Natives. In the United States, there are 573 at the last count, I believe, federally recognized tribes. That's a lot of different groups of people, and most of those are pretty small groups of people when you think about the number of people that are collected in the SEER database and the number of people that live in the United States. And so understanding exactly what's happening in these groups of people has a lot of challenges. One is their very small relative population size. So think of the last paper that you read where they mentioned race or ethnicity. You probably saw white or Caucasian, you probably saw Black or African American, you probably saw Hispanic, you probably saw Asian or some description thereof, and then you probably saw other. You might have seen American Indian, Alaska Native, but typically they are either undercounted, so not well identified, or lumped in with other because of the small relative numbers. Even if you see a distinction of American Indian or Alaska Native, this is aggregating every tribe and region in the United States, which vary quite a bit in terms of their practices and their health promotion strategies and their culture and what sort of lifestyle they have and what their own specific history is in the region that they live and if and how they were marginalized there. So this is really challenging when you look at big databases or when you look at national numbers. So estimates for misclassification of American Indians range from 10 to 35%. So they vary a little bit by region, but that is a huge number of people. In our own health record here, the University of Minnesota Fairview Health System, you really cannot identify anybody that is or is not American Indian. It's very unreliable. Genetic variations may contribute to disparities amongst American Indians and Alaska Natives because these different tribes and their different groups of people that are lumped together for, you know, epidemiological and data collection purposes, they may have very different genetics. There certainly are some studies to suggest that. For example, nicotine metabolism may be different amongst different regional populations of Native or Indigenous peoples. And then, of course, lack of access to high quality cancer care may definitely contribute to worse outcomes. So this is an example of what's called the Contract Health Service Delivery Area counties. So the counties are the little red dots, the counties. And then, of course, the states you will recognize outlined in this orange color. And then they're divided here by these Indian Health Service regions. So, of course, there are federal organizations devoted to Indian affairs. And so the Indian Health Service has regions nationally that they do. These are administrative regions, essentially. So, of course, Minnesota here is in the Northern Plains regions, but this does not actually have any bearings on the tribes in this area or the groups that live in this area. These are, essentially administrative delineations here. So this paper, and I apologize, I don't think it's very good quality, and I tried my best to make it better, but this is from a paper that was published a few years ago, and this is trying to get away from the broad strokes of national data that tell you a story about American Indians and Alaska Natives that might appear one way on the surface, but is a little bit different when you dig into the data. So when we talked about incidence in the beginning and the numbers that I showed you about national data in lung cancer, American Indians were somewhere in the middle, and those first few graphs didn't really display them in any way that was particularly meaningful or dramatic. So the purpose of these graphs, the lead author on this paper was Chris Rhodes, who is the CEO of the American Indian Cancer Foundation, which is actually based here in Minneapolis, and she was on faculty at the University of Minnesota. So they looked at individual tribes areas. So you can see Northern Plains here. So they looked at those Indian Health Service regions to try to get a more refined understanding of what is happening with lung cancer in these groups. And so on this graph, lung cancer mortality is related to percentage of current smokers. So the American Indian Cancer Foundation has done studies to get accurate reports of cigarette smoking amongst American Indians. So these numbers are more accurate than some of the other numbers that you might find. What you see here is that as the percentage of current smokers goes up, there is a direct relationship between lung cancer mortality in these Indian regions. So Southwest is down here, and they've got women and men listed out separately. Pacific is in the middle, and of course Northern Plains men is up here. So like other groups, men are still leading the way with lung cancer mortality. However, the other thing that they show here is percent change in current smokers. So looking at trends over this 30-year period of time in cigarette smoking in each of these Indian Health Service regions. And they are seeing an increase in lung cancer mortality in women, specifically in the Southwest, related to increase in percentage of current smokers. So they're smoking more, and now they are developing lung cancer more as well. So, this slide does show that there is a strong association between cigarette tobacco smoke and lung cancer in American Indians and Alaska Natives. But that's not exactly what I want you to take away from this slide or from this presentation. So the relationship between commercial tobacco, cigarette smoking, and American Indians is quite complicated. It has roots in traditional cultural practices using other plants, not what we currently use and could buy at the store as cigarettes, for cultural purposes, for healing purposes. So I have a couple of quotes here that I'm going to give you a minute to read, since they said it better than I can say it. This is from a narrative article published by some elders, most of whom are from Minnesota, who are of Ojibwe descent, and that is one of the tribal cultures that does strongly include tobacco smoke in their practices. So the title of this article is "Why the World Will Never Be Tobacco-Free, Reframing Tobacco Control into a Traditional Tobacco Movement." And so the American Indian Cancer Foundation and others have started to reframe sacred tobacco use as something that is traditional and is cultural heritage, but is not for recreational casual use with commercial tobacco cigarettes. I think this is really important on a discussion like this because I will reveal my own ignorance, and I'm sure many of you will recognize this thought that you may have had amongst yourselves, which is, well, why are you smoking so much? You should quit smoking. Then you would have less problems with lung cancer and, of course, lots of other diseases. But this article talks a lot about how tobacco-free is not a possibility, but instead we need to have a culturally relevant approach to tobacco, and the origins of commercial tobacco use are, based in colonialization, being unable to access their traditional plants that they use for this, and being told, this is your cigarette, right? You've seen American Spirit cigarette packages and a lot of native themes. So many American Indians are misled essentially by the tobacco industry, which of course is not an unfamiliar story. However, I have some good news. So this study looked at survival for non-small cell lung cancer in US military. So military members as well as their dependents who were receiving health care in VA and military institutions. So this is a survival curve looking by stage. So again, you see, what we always see in lung cancer is that stage is an important determinant of survival. So stage 1 is at the top, more advanced stages 3 or 4 are at the bottom here. And they showed that this held up when you looked at race groups. So essentially the conclusion or the main discussion point for this article was that with equal healthcare access, you can do a lot to narrow disparities in lung cancer survival when everybody has access to care and the cost of care is less of an issue. I have another piece of good news for us, especially here. This study looked at where people lived and where they got their lung cancer or any cancer care. Actually, this was all cancer mortality. And they showed that for people who received treatment at NCI designated cancer centers, race differences completely disappeared. So that's encouraging. I'll talk a little bit about screening and tie that back into disparities. So the National Lung Screening Trial was published in 2011. It was a randomized controlled trial sponsored by the NCI. They enrolled 53,000 people at many sites throughout the country, including the University of Minnesota. One of our researchers here, Dr. Tim Church, was involved. In the National Lung Screening Trial, they enrolled people who were age 55 to 75 years old. People who had smoked 30 pack years, so the equivalent of a package a day of cigarettes. If you recall my colorful graph from earlier, that's 20 cigarettes per day at least for 30 years. And if they had quit, they quit for fewer than 15 years. In this study, individuals were randomized to receiving an annual low-dose CT scan or a chest x-ray every year for 3 years, and then they were followed for another 6 years. So this study showed a reduction in lung cancer deaths. The study was actually stopped early once they achieved significance, which shows a relative risk reduction of 20% of lung cancer in the screen group, the CT group, and an absolute risk reduction from 1.7% to 1.4%. And then also they showed a reduction in all-cause mortality, which was not very well explained, honestly. So on the basis of this study, the United States Preventive Services Task Force is the group that makes recommendations for all preventative care, vaccines and cancer screening and all of that kind of stuff. So they recommended in 2013 annual lung cancer screening with a low-dose CT for people who are age 55 to 80 and who smoked at least 30 pack years. So either current smokers or quitting in the past 15 years. So essentially they used the entry criteria for the trial. They did extend the eligibility age based on the fact that people who entered the trial were 75 years old. They got screened for 3 years and then they were followed for another few years. So they sort of extrapolated the findings. If you have been paying very close attention, you may have noticed that there are some people who are left out. So high-risk people who do not meet these USPSTF criteria, specifically smoking intensity, are left out of screening at this point. A recent analysis found that African Americans were more likely to be considered ineligible based on a variety of there's some minor modifications to those screening criteria that have been proposed, but essentially they're all kind of checkbox. Age checkbox, smoking history, the back of the envelope calculation for how many cigarettes per day and how many years you did that. And by most of those criteria, many more African Americans were likely to be ineligible for screening for lung cancer. So the National Lung Cancer Screening Trial enrolled 90% white individuals, and 59% of them were men. So when you have African Americans who smoke less intensely and are diagnosed earlier, they are much less likely to meet eligibility for lung cancer screening. And so they were not included in that trial. And then the American Indians, the percentage of those was less than 1% in the National Lung Screening Trial. So we don't really know what the impact on that group of people would be from screening. There are some individualized risk calculators out there. The most popular one has quite a few criteria that it includes to determine a specific individual's risk for lung cancer. And as you'll notice, we'll really factor in a lot of the stuff that we talked about today. So race is an important component of the individual lung cancer risk model. Family history, so that kind of gets to the genetics. The presence of lung disease. Education level, which is our socioeconomic status indicator, cigarettes per day, and duration of smoking. So those are already included in the smoking, in the current screening guidelines. They also include gender and body mass index. So if you use individualized risk calculators instead of the checkbox of age and smoking intensity, you would greatly improve the efficiency of screening. You would find more lung cancers, and you would screen fewer people who do not develop lung cancer. So this modeling showed that using this individualized risk calculator would increase the inclusion of African Americans from 7 to almost 13%, and potentially prevent 20% more lung cancer deaths than using current recommendations. So contributors to disparities in lung cancer are, of course, multifactorial. It's not a simple problem. Societal factors that include access to healthcare, health literacy, socioeconomic status, belief systems. I think this one certainly is important when we talk about American Indians, but really there are different beliefs that seem to be more prevalent in different groups. Insurance status, as I mentioned, stage at presentation is a huge one. Environmental impacts or environmental factors, so pollution and geographic location, whether that's rural versus urban, or exposure to pollutants in an urban area, alcohol use. Biology certainly plays a role, but it's probably a fairly small role in terms of the disparities in lung cancer. Early detection, so eligibility for screening, uptake of screening, so access to and completion of screening. And then, of course, there are smoking characteristics as well, which contribute. So what can be done? We talked about brainstorming solutions. I'm hoping people here will pipe up and offer some input. One thing that could possibly be done is modifying screening criteria. This is a hotly contested topic right now in the screening world. We have only been screening for a few years. Probably will never have another 53,000 randomized controlled trial to demonstrate this, but certainly modifying screening criteria does have the potential to change and to narrow the disparities in lung cancer. Of course, improving access to care, which could be multiple talks in and of itself, on which I'm not an expert, but improving access to healthcare would almost certainly improve lung cancer disparities. Reducing environmental exposures. So radon is a particularly important one in this area, but there are plenty of other environmental exposures which likely have a contribution to lung cancer. For example, environmental exposures, if you want to talk about cigarette smoke exposure, many casinos, of course, you can still smoke in. So if you live on a reservation and work in a casino, not only is your own personal cigarette smoke exposure important, but your secondhand smoke is important. Culturally relevant smoking cessation, and this applies, I think, not only to to American Indians, but also to African Americans. And then I think what's really important is to increase representation in healthcare delivery, as well as research, to overcome a justified mistrust of research. We don't have enough minorities included in research to really understand how we can improve things, and justified mistrust of healthcare systems and systemic racism. So with that, I would be happy to start a lively conversation.
I have the microphone we want to use for the benefit of our people in Duluth and Hormel.
So Abbie, COPD is an independent risk factor for lung cancer. That's now been proved both epidemiologically and at the molecular level. How does that factor into disparities in terms of cigarette smoking intensity, frequency? Does that also used in the risk calculators that are being proposed? Could you explain a little more about that particular issue? Because it used to be thought, of course, that it was just concurrent.
Right.
But they're independent.
Yes. So the easy answer to one of the questions that you asked is yes, it is included in the individualized risk model. So that's where the presence of lung disease comes in. Yep. I think in terms of because you're right, it has been shown that COPD is an independent risk factor for lung cancer. Of course, the most common risk factor for COPD is cigarette smoking, but other environmental exposures as well. So it might be occupational exposures, it might be secondhand smoke exposures, it might be pollution exposures, depending on where you live. To my knowledge, that's the main thing that I've seen in the health disparities space, or is that?
I guess what I'm asking is, if you added spirometry, which is cheap and it's done in any clinic.
Yeah.
Can that improve either the access, any of the things that we do to try to prevent these disparities and the disease and improve outcome from the disease itself?
I don't think we know the answer to that question. And so I think on the one hand, yes, it makes sense. You're right. Spirometry is easy to do. It's pretty cheap to do. Current recommendations don't advise, screening asymptomatic people, but that probably, you and I are pulmonologists, and we both know that there are plenty of people who are not quite asymptomatic who might never get screened. There are plenty of people who get labeled as COPD without ever having appropriate testing done. I think we actually looked at measuring individualized risk in a population of American Indians and doing spirometry to contribute to an individualized risk calculator. I think it would probably impact, more importantly than lung cancer outcomes, it would probably impact overall mortality, because you may be identifying, in American Indians, I think chronic lower respiratory disease is like the third leading cause of death. So I think it would probably more likely impact overall mortality than lung cancer specific outcomes.
So thanks for the talk. So, it was really striking how you showed data that if you smoke 10 or fewer cigarettes per day, you see striking differences between groups of people who have different ancestry. Because there's this big literature on chemo prevention or diet and nutraceuticals that may influence the metabolism of tobacco products. I'm wondering, is there any evidence in this country or by comparing with other parts of the world that the diet, besides just the BMI, is affecting your risk for cancer at these low doses, lower amounts of cigarette smoking?
I think that's a really great question. I don't think I've ever thought of it before, and I'm certainly not aware of specific data, but I think you are right. Many of us can imagine health food deserts where there's maybe some evidence that cruciferous vegetables, for example, may have preventative effects for lung cancer. And I think you certainly imagine the health deserts where you might see these types of things, and people who are efficiently smoking their 10 cigarettes a day and probably not having a lot of Brussels sprouts at their most local grocery store. But I'm not aware of any data.
Hi, Abbie. Great presentation.
Hi, Dana.
Just kind of looking at those factors up there in our work with the American Indian population, I'm just more and more getting focused on the role of stress in health disparities. And I wonder to the extent to which your thoughts on how that can contribute to lung cancer disparities. I guess it gets maybe potentially captured in education there, but kind of just with the findings with the socioeconomic gradient, it just made me think about how maybe stress may be contributing either biologically or just kind of interested in your thoughts.
Yeah, I think there's probably a couple of different ways to answer that. I mean, the short answer is that I don't, there aren't any studies that necessarily show that I'm aware of, but certainly one is the stress, the trauma of being in a marginalized group, right? And the additional barriers that you face in everyday life, including maybe access to healthcare, including how you're able to best care for your health, including how you're able to quit smoking and undergo screening and accept whatever treatment is recommended for you. I think the other part of that is the stigma associated with lung cancer, which may not actually be a disparities driving feature. In fact, it might be different because in our work in American Indian clinics, there's certainly a lot less stigma with smoking cigarettes there. So people are less, hesitant to seek care for that. But when you talk about lung cancer in general, I think the stress of anticipated stigma and well-documented stigma does play a role in how people seek care and their willingness to undergo screening, willingness to undergo treatment. So I think there's a couple of ways that impacts lung cancer in a way that's really different than other cancers. I heard a really great speaker talk about stigma recently, and he said, how many people know what a mammogram is? How many adults know what a mammogram is? 99.9, everybody, even though half of them don't ever get one and never will need to get one, right? He's like, how many people know what a low-dose CT is and what it's for? He's like, we have a long way to go with awareness and understanding about screening for sure, but also the stigma of a smoking-related disease. So I don't really have a good answer to that question, but I can certainly talk about it for a while.
So, Abbie, excuse me, that's a follow-up question to the thing you just mentioned. So,
Yep.
For access to screening, how much are financial barriers a problem? You pointed out lower socioeconomic status is associated with poor outcome on all factors, and I just wondered about this aspect. And I bring it up because, the state does support mammographic screening for, they pay for it.
Mm-hmm.
And USPTF has a lower recommendation for mammographic screening than they do for lung cancer screening.
Mm-hmm.
So I'm just wondering, of the patient population that is eligible for screening, how many people are actually doing it? And then secondly, is there a disparity based on ability to pay for it? And I guess the third thing is, since you manage this clinic, what do you do when people wander in and say, I want to be screened, but I'm not insured or I'm underinsured?
Yeah. So, yes, you're right that the state, pays for mammography. So in Minnesota, we're lucky, actually. We have pretty good state Medicaid coverage. I mentioned that Medicaid is a state level and essentially for people who can't afford insurance or, they have other criteria. But and so the recommendations for screening nationally are for Medicare, but at the state level, the state Medicaid can determine their screening eligibility. So Minnesota Medicaid does cover screening exactly the same way that Medicare covers it and most private insurance companies. So from that perspective, we're lucky. Again, that only applies to these specific screening criteria. And so, as I mentioned, other people may be at higher risk for lung cancer. Right now, it's not recommended to screen people who are at high risk but are not eligible because many of those people may also have higher competing causes of death. So if they may have higher likelihood of dying of cardiovascular disease or other cancers. And so certainly we don't have evidence to support that we are going to, from a screening perspective, really make a big difference if you screen people who are high risk but outside of the NLST or USPSTF criteria. So when they come to me, we do have and then you mentioned uninsured people. So we actually have a screening grant here, which is a small grant that was awarded to us a few years ago by by A Breath of Hope Lung Foundation, which is a local lung cancer foundation. And the purpose of that is to screen people who are eligible but not insured. We haven't used very much of that money because we do have a pretty high insurance rate here, and Medicaid covers it. But that money would be available to somebody who is eligible to be screened, who could not afford the screening. The problem, of course, that you get into is once you get screened and then you find a bunch of stuff and then you don't have insurance, how do you help those people cope with that problem? And then the other thing I want to point out about the state covering mammograms, since we talked about it, is I'm blanking. I know you know the name of it. What's the
SAGE?
Yes, thank you. So the SAGE program is a Minnesota Department of Health program to bring cancer screening to underserved people, and they cover colon and breast cancer, I believe, but of course they haven't even touched lung cancer screening. Every time I run into a SAGE person somewhere and I want to talk about lung cancer screening, they turn around and run away from me because it's a lot more complicated than some of the other cancer screenings, due to incidental findings, due to a little bit more complicated eligibility criteria. Lung cancer screening can be done very poorly, and when done poorly, the risk probably outweighs the benefit. And so understandably, they're not trying to just do it everywhere, and it's expensive too. Yeah.
Hi, Abbie. I want to
Hi.
thank you for the research that you're doing, because I know there's a lot of lack of research on health disparities among minority groups. And my question to you was, from the subgroups, it was surprising to me to see that Latinos and Hispanics were the lowest in having the incidence rates of lung cancer and mortality rates, especially, in the US, there's a huge population of undocumented Latinos and you mentioned that access to healthcare is one of the major contributors to this disparity. So I was wondering if you looked into the research why Hispanics have the lowest.
I have it, but I'm guessing that it probably can be described with, so the work that I've done has focused primarily on American Indians, and I'm also more interested in delving into African Americans. And so I have made extraordinary efforts to find that data, right? Because the national numbers tell you one story, but when you get onto a local level, so I'm certain that it probably varies by location, right? It probably varies by what groups are living in a specific area, what social network or what safety networks are available in that area, what their smoking rates are like due to either cultural reasons or local factors. So all of the data that I saw that was national kind of gives the same picture of like lung cancer is less of a problem for these groups of people, right? But I suspect there's a more complicated story beneath the surface there. I have not come across anything to that respect, and I that may be partly where we are. We have more American Indians here. That's kind of another sort of a more obvious subtlety, if you will.
So I just wanted to come back to Doug's question, because I think there's a real opportunity here. Abbie described that we're 6 years or so into embarking on lung cancer screening. And, we don't have to make the same mistakes that were made with mammography and cervical cancer screening and colon cancer screening. We know a lot about how slowly that is going to be disseminated to different groups. And I do think there's the potential to sort of be proactive and forward thinking about this and try to compress that pattern. The other thing is that even without considering disparities, probably in the single digits percentage of people who are eligible for lung cancer screening in the state of Minnesota are getting screened now. It's just it's still a very, very new practice. So matching up people who should be screened with screening services, I think is a huge opportunity and even a research opportunity. And I don't know if you're going to mention this, Abbie, but Abbie is working with David Haynes, who's a new faculty member, who should be able, together, they should be able to describe in a more detailed geographic way the location of people who are likely to be eligible for lung cancer screening and services in the state of Minnesota.
Thank you, Anne. That was one of Doug's questions that I forgot to answer, but yes, as current estimates are between 3 and 6% of people who are eligible for lung cancer screening have been screened.
Hi. So, screening is great. New treatments are great. Identifying targeted therapies is great. But nothing's going to be lung cancer like prevention in the first place, preventing smoking. And to what extent are there disparities in smoking uptake in the groups that are most likely to start during adolescence, early adulthood? How can efforts be targeted to those groups to prevent the disparities from happening later down the road?
So
it's not. I just note prevention wasn't on your list of actions that can be taken to change the picture of lung cancer mortality.
Yes, you're right. I didn't make that the big thing in bold for a couple of reasons. Reducing environmental exposures and culturally relevant tobacco cessation is what I have here. The two reasons I haven't put that as the main thing are, of course, it's very important. I think to some degree that can also contribute to the stigma of lung cancer by talking about prevention as the number one way to fix things. I mean, it is, obviously. I believe that, and I do it in my practice, and I'm a lung doctor, and I know all that stuff. But I think with regard to how we can target, tobacco reduction in specific groups. So for example, in American Indians, estimates are that 60% of Native Americans in Minnesota currently smoke tobacco. So that's much, much higher than, of course, national numbers or Minnesota numbers, which are, I think, in the 12 to 14% of adults using tobacco. I think how we address that population, of course, is very different than how we talk about other populations. And so there are efforts in that community to keep tobacco sacred, which means tobacco is used for ceremonial purposes. It's not necessarily smoked. It's used in other ways, but is not used for recreational purposes, and working towards that message. The article said, we will never be tobacco free, but doing it in a way that is more culturally relevant, or more culturally sort of appropriate and less toxic, essentially. I think that story is different for other groups, right? So for African Americans, sort of they have higher smoking efficiency, even though they have lower intensity, probably environmental factors, whether that's, shared housing and exposure to secondhand smoke, whether that's availability of tobacco and advertising in neighborhoods that are predominantly African American. So I think the approach is different for each sort of group. But you're right. I mean, it is very important. So I don't disagree with that.
Any other comments or questions?
I got one over here, and then I got to run to clinic.
Thank you for the great presentation. So you mentioned that smoking topography is a more nuanced measure looking at efficient absorption of nicotine. And I'm curious why that indicator wasn't included in one of your in your individualized risk calculator.
Well, this is not an individualized risk calculator that I came up with. This is it's a risk model that was done and validated in large screening studies. I think the short answer to that is that it's really complicated. There may be a more nuanced answer that you want to share, Anne. I don't know in terms of smoking topography, but I think it's, in terms of in nicotine and tobacco cessation research, that's pretty complicated to measure, investigate, and report. And, an individualized risk calculator calculator is only going to work as well as a person who's taking care of a patient can extract that information, right? And so that the more complicated you get, the less practically useful a calculator can be. But I think, I don't know if you want to add anything to that.
I think that's, and we know, so for example, on average, people take 11 puffs on a cigarette, but there's a range within each individual, and what they did in 2000 versus 2019, you could never recover that information. So I think Abbie's right on there. It's very difficult to measure, unless it's like in a lab.
One more, and then we'll have to go.
Well, I might have two comments.
Okay.
There's no good lung cancer talk without talking about e-cigarette and vaping. Do we know anything how many Native Americans already picked up these bad habits?
So certainly people are picking up the bad habits at high rates, young people especially. All of the sort of alternative smoking lifestyles, if you want to call it that, vary in terms of their likelihood to cause cancer versus likelihood to cause lung disease. For example, if you think about hookah, you think about electric nicotine delivery systems. If you think about smoking marijuana, for example, we don't have any really data to talk about cancer because electronic nicotine delivery systems are very new, and vaping. Even with marijuana, we don't have great information about cancer because many people are co-smoking both of those things. So those are kind of the really wild west in terms of this conversation. Vaping is probably less harmful than combustible tobacco cigarette when it comes to cancer. Maybe not so much for other lung damage, right? But when it comes to cancer, it might be less harmful, but we don't really know. I mean, we don't have enough time for sure to demonstrate that. I saw you cringe. What's the matter?
Don't say less safe. My other topic I want to make is a little unrelated to what I asked earlier. You had this citation from this native Indian about the cultural use of tobacco.
Mm-hmm.
I wonder if somebody could just do an education campaign and teach these Native American that the cultural use of tobacco with using raw tobacco leaves is a completely different way than using a cigarette, because cigarettes are pharmaceutically sugar, caramel flavored devices. They are just drug delivery devices. And there are 100 YouTube videos out how cigarettes are made. And I think we should show these every morning at 8 o'clock on TV for 4 hours. Mm-hmm. Because cigarettes are just terrible. But these raw tobacco use in cultural thing is different. And I would be not surprised when the Indian culture would say, wait a second, this cigarette is really not tobacco.
Right.
Let's do the other stuff, and then they would just drop it.
No, you're absolutely right. Of course, there's a lot of cultural and historical background here, but certainly the people now who are working in this community to do this absolutely recognize that, and that is their goal. So cigarettes were, totally fabricated and marketed and sold as the thing that they could get when they could not access the plants that they traditionally used. I would strongly encourage you to find this article and read it. I think it is really, really insightful to anybody who does tobacco work or cigarette work, because I think I will tell you, the first few years of our work with this community, I thought, well, okay, that's great. I get it. I'm not going to harp on you, but still, it's bad, you have to stop, right? I mean, I still had this, I don't understand why, whether or not it's cultural or it's recreational or you're being a rebel or why you're doing it, it's still bad for you, right? But I think reading this article is really gives you some insight into the problem, the scope of the problem, and how you have to be careful how you talk about it, but also pushing for sacred use, which you're right, does not involve smoking. Okay.
Great, let's thank Abbie again.
Thanks very much, everybody.